Welcome to this medicine masterclass on asthma. We will be taking a case-based approach, considering the expected findings on respiratory examination and followed by a discussion. On examination, start by thinking about the findings you'd find on inspection. On inspection of a patient with asthma, the patient may appear tachypneic with an increased work of breathing. The chest would appear normal with no scars in lung asthma. The cricosternal distance would be expected to be normal, unlike COPD, where there is a hyperinflation of the chest causing a reduction in the cricosternal distance. Chest expansion would be equal, symmetrical, both anteriorly and posteriorly. Percussion, you would expect normal resonance throughout, and on auscultation, decreased air entry throughout both lung fields with a polyphonic wheeze. Differentials would include asthma, emphysema, bronchitis, and COPD. So this will be presented as Mr. Williams presents with wheeze, the patient was comfortable at rest, and I believe the patient has signs consistent with asthma. From the end of the bed, the patient appears tachypneic. The patient is using their accessory muscles breathing. There was no evidence of nicotine staining on the digits. On inspection of the precordium, I noted a normal shaped chest, no evidence of tracheal deviation or tracheal tug, and the chest wall movements were symmetrical. Percussion was resonant, and on auscultation I noted decreased breath sounds, a marked polyphonic wheeze, and the JVP was not raised. And the differentials, as we mentioned, asthma, emphysema, bronchitis, and COPD. Discussing asthma. Asthma is an inflammatory disorder characterized by hyperresponsiveness of the airways to multiple stimuli, resulting in widespread reversible narrowing of the airway. The pathology is mediated by T lymphocytes, mast cells, eosinophils, and a wide range of other inflammatory mediators, resulting in bronchial smooth muscle contraction. In extremis, patients can develop acute severe asthma or life-threatening asthma. Acute severe asthma is defined as when the patient is unable to complete a sentence in a full breath, they are tachypneic with a respiratory rate of more than 25 breaths per minute, and they are tachycardic with a heart rate of more than 110 beats per minute. The peak expiratory flow rate is between 33 and 50% of predicted. Life-threatening asthma is where the peak expiratory flow rate drops to less than 33% of predicted. The patient starts to become tired and exhausted. They may become confused and develop a coma. The chest may become silent. They may develop cyanosis with a poor respiratory effort. And importantly, the CO2 can be normal or raised. You would expect in a patient with severe asthma who's tachypneic, who's breathing very hard, that their CO2 would drop due to the excessive breathing. But when the CO2 begins to climb, it implies that the respiratory effort is now compromised, and so a normal CO2 is severely worrying in these patients. They may also have hypoxia with a PO2 of less than 8 kilopascals, and the pH may begin to fall. These features would require intensive care. Brittle asthma is characterized by life-threatening asthma attacks which can develop within hours, minutes, and can precipitate death. In general, the presentation of asthmatics would be shortness of breath, wheeze, reversibility, some diurnal variation, which means that in the morning their peak flows dip, chest tightness, a recurrent cough, particularly post-exercise, and they may have occasional fevers which can be associated with eczema, rhinitis, nasal polyps, or esophageal reflux. The signs and symptoms can be triggered by cold air, emotion, dust, pollen, viral infections, and pets. On examination, patients will be tachypneic. Their accessory muscles may be used, the sternocleidomastoid. You may see the intercostal muscles being used. They may have pulsus paradoxus, which is where the pulse drops on inspiration, hyperresonant percussion, bilateral polyphonic wheeze, and in the more severe asthma conditions that we mentioned, they would be unable to complete sentences and start to become exhausted. So to manage these patients, it's important we recognize the chronicity of this condition and employ a holistic patient-centered approach with a multidisciplinary team employing conservative medical and interventional options. Conservatively, educate the patient about the condition, address the biopsychosocial implications of the diagnosis, encourage smoking and alcohol cessation if relevant, help them avoid precipitants where possible, minimize exposure, occupational exposures, and provide a written specific plan about what to do in an emergency. Now, medically, the British Thoracic Society provides guidance. In the first instance, a short-acting PRN, when required, beta agonists such as salbutamol can be used for symptom relief. If this is used more than twice a day or at night, the patient should be escalated to step 2. A standard dose inhaled steroid such as beclomethasone should be added. If despite this symptoms persist, then instead of a short-acting beta agonist, a long-acting beta agonist such as salmeterol should be used, and the inhaled steroid dose should be increased. In step 4, for patients who still require additional therapy, higher dose steroids can be used, oral theophylline can be added, a modified release beta agonist or an oral leukotriene receptor antagonist such as montelukast can be used. And the 5th step of the BTS guidelines is to add regular oral prednisolone, the lowest daily dose possible. And here is a visual guidance of the British Thoracic Society guideline summary, where step 1 for mild intermittent asthma, a SABA should be used as short-acting beta agonist. Step 2, an inhaled steroid is added, and that should be proportional to the severity of the disease, and this step 2 is known as regular preventer therapy. Step 3, which is the initial add-on therapy, is where patients are still not controlled. A LABA is introduced, the long-acting beta agonist, and if there's a good response, the LABA is continued, but if there's an inadequate response, then the corticosteroid is increased, the inhaled corticosteroid is increased, and if there's no response to the LABA is stopped, the corticosteroid is increased, and other therapies such as leukotriene receptor antagonists are introduced, or theophylline. In step 4, which is used for patients with persistent poor control, trials of very large inhaled doses of corticosteroids are used, and a 4th drug such as theophylline can be introduced, or a beta agonist tablet. Step 5, for those patients with continuous or frequent use of steroids, an oral steroid tablet using the lowest possible dose can be introduced, and other agents can be introduced by a specialist centre. Importantly, BTS guidelines advise that when the symptoms are under control for 3 months, then de-escalation should be considered. Bear in mind, of course, that rescue courses of steroids can be given at any time during an acute exacerbation. Essentially, the pharmacotherapy principles, beta agonists are there to relax the bronchial smooth muscles by increasing cyclic AMP levels, and these can act very, very fast. They can be given inhaled or nebulized, orally or intravenously, depending on the severity. The side effects include tremor, hypokalemia, tachyarrhythmias, and anxiety. Steroids are given ideally through the inhaled route to reduce side effects, systemic side effects, or can be given intravenously or orally if required, again depending on severity. Patients should be encouraged to rinse their mouth after using inhaled steroids to decrease the risk of fungal infections. Aminophylline, which is metabolized to theophylline, inhibits phosphodiesterase and increases the levels of cyclic adenosine monophosphate to reduce bronchoconstriction. And this also can be given orally or intravenously. This drug has a narrow therapeutic index, can cause arrhythmias, GI upset, and seizures, and so needs regular and close monitoring. Anticholinergics are there to decrease bronchial muscle spasm and are useful in COPD. Chromoglycate can also be used, particularly in the prophylaxis of exercise-induced asthma, and is particularly useful in children. Leukotriene receptor antagonists such as montelukast, zafrelukast, these block the effects of leukotrienes in the airways and act by antagonizing the effects of the CYST-LT1 receptor to increase airflow. Anti-IgE monoclonal antibodies such as omalizumab can be used in highly selected cases of patients with persistent allergic asthma, and this is given as a subcutaneous injection. Thank you for attending this medicine masterclass.